Welcome friends to our NPTEL MOOC module on health economics. This course is considered to be unique in the sense that this is largely explaining all mathematical theories and healthcare as well as its applications, and you may consider this as your credit course maybe in IITs and even in universities model as well. I think as per the NEP it is required to go for 40% of the content from online module. I think we are covering all perspectives, and from our lecture you will have the freedom to appear answer 50% of the questions. Okay, I am sure you will enjoy the course. In this lecture we will be emphasizing on Grossman's model and health disparities. Why Grossman model? Because we discussed already in our previous lecture, isn't it so? We discussed Grossman model of healthcare demand. Even we also discussed for utility and health, we discussed for demand for healthcare. Alright. Now what are there in this chapter? In this chapter we have a different perspective and comparing with the Grossman model. However, let us recap what we did it. We discussed about Grossman model of demand for health, explanation for differences in efficiency of producing health with education and aging within Grossman's settings. Here we are emphasizing on Wagstaff 1986 paper and the explanation on healthcare disparities in the context of socio-economic differences or disparities, and also while with the comparison with Grossman's model. We will be also summarizing the entire week, since this is our 10th lecture and that is the end of the week unit number 2. We will be also summarizing the entire week's lectures. Here it is the Wagstaff model of demand for health. We will be explaining 4 quadrant, comparing each of the categories. We have taken 4 aspects: consumption, health inputs, in fact 3 variables, but we are connecting each of their relationship. We start with the production possibility frontier with the relationship between consumption, that is we are referring to X commodity, okay, other commodities which we already discussed, and H here we are actually emphasizing health as the commodity. And if an economy is actually emphasizing on these two, how much maximum consumption commodity or health commodity is possible. This is what is discussed in the one diagram. Now the maximization point is satiated or explained with the indifference curve, and we have emphasized here, okay, through the indifference map, and then we discuss its equivalent production structure and which requires of course is health inputs. Health as a product, as a function of its inputs, okay, inputs, health inputs which I have already discussed. So it is upward sloping, and it is attached with diminishing returns to scale principle as well. Hence there is a backward bending directions as well. Now on the third one we are explaining how far the budget is actually allocated between health inputs as against the consumption goods, okay, to maximize our satisfaction or maximize our utility through maximum production. Now here actually we are presenting the relationship between consumptions of this for an individual income point of view, as we know that this is basically 45-degree line. Now we discuss all those possible points and its mapping. You can just have an idea. Therefore, the first diagram is on welfare possibility frontier, since we are emphasizing in terms of the maximum possibility of X as against health. And second one is health production function, third one is our budget constant, fourth one is our just relations between these two in terms of our income, okay. And more of this possible with higher combination of these two. Okay, now we are clarifying all those things one by one. We just said that income of the individual if decreases, then what will happen? The budget line goes inward. Okay, there will be a backward shift. And what are the implications of this backward shift? We know that the welfare possibility frontier changes its shape and position. This is what happens. There is a backward shift as well, and this leads to lower income. That means the feasible combination of H and X available to the individual. Okay, so hence it will have a lower combination of X, H and X, and hence the low income that leads to less spending available for health inputs, and hence low health. So basically here we just wanted to draw that health inputs, if you have low, then your health outcomes are also considered to be less. Okay. This suggests supplementing income to the poor people, since they usually carry poor health, and hence health inputs are less, and eventually they will be in a trap, there will be a health trap. Now we are explaining another context, effect of change in prices. Price of the inputs, if any are there, like if health inputs are very expensive, what really happens? Our choice function is actually compromised in terms of healthcare. Yes, these have implications on our choice function as well. That leads to reduction in our overall choice. So what really happens? With the rise in the prices of health input, this leads to demand for health inputs declines. Okay, and this leads to health of individuals also declines. All right. So this is what is mentioned. You can just have a check. Now we are actually landing on another point in all the cases. Hence this requires subsidization. This is what I wanted to conclude. This requires subsidization. This records the subsidies on health inputs is very required, since we have started with, if any higher prices of health are there, some subsidies are actually warranted. Now let us have some understanding on change in technology. If technology increases, what really happens? This is explained over here. Our production possibility, our production function will be shifted rightward. Okay, this is what is explained. And yes, since it is positively changed, it has implications as well. Health production function shifts upward. This will have welfare possibility frontier, and hence its shape will also be different, and we have higher possibilities, and our welfare is expected to be higher. One such example is through education. If education enhances the enhances the skill, and the technological upgradation is also possible. So spending on education is very efficient, and is very good. That lead to efficient producers of health. Hence the production function goes upward, and that leads to income, spending on health inputs also increases. Okay, this is what is health inputs also increases, and eventually the demand for health also increases. All right, you can just have a check. All right. And the third one we wanted to, third one we have just emphasized in terms of technology. Now we have explained in the context of education, and this is in fact the key where we started discussing with the Grossman model as well. But Wagstaff key predictions are explained through three directions which we discussed. One is increase in price of health inputs, that should lead to a deterioration of health status. A reduction in income will cause larger deteriorations in health at lower levels of income than at higher levels of income. And third one is in terms of education technology, that is precisely mentioned as better educated should utilize fewer health inputs and yet be in better health than poorly educated. So, the disparities are actually discussed in terms of income, in terms of education, etc. In Wagstaff model, we found that health and socio-economic status are very relevant. They have causal relationship. Yes, other factors are also affecting these two as well. Now we are discussing all those explanation of socio-economic disparities and healthcare implications through different hypotheses. So, we have here seven hypotheses, starting with efficient producer hypothesis, and different literature, different experts have actually emphasized in different context. This might be useful for your research. One is called the efficient producers hypothesis. This simply says even in the first five are emphasizing on socio-economic status, okay, that has implication on healthcare, and other two are little different. They start with like productive time hypothesis, emphasizes the role of health, how it has connection with socio-economic status, how health implies different socio-economic status. Whereas the Fuchs hypothesis is largely on time discounting. We also discussed to some extent in our earlier lecture, and that is basically emphasizing on the discounting method. And they have discussed the role of other variables, how other variables implied or has implications on socioeconomic status as well as on healthcare. Okay. So, we will be discussing each of them one by one. Here are the details. We start with efficient producers hypothesis. This is precisely mentioned as better educated individuals are more efficient producers of health than the less educated individuals. There are different mechanisms by which this is attained. If education is there, then there will be better self care, and education is through schooling. If any that that have long term investment in healthcare, and that led to more patient approach, because schooling gives the quality education to the individuals, and that will have a long term implications. Hence, it is discussed as long term investment. Similarly, there are implications such as adherence to treatment regimens, then better ability to navigate complex treatment plans through education. Grossman's model largely predicts the same as people with higher education have higher health investment or higher production capacity. Hence, the socio-economic disparity in health between educated and non-educated is noted. Through Grossman, we can also interpret these two as well, socio-economic disparities. Now, we are emphasizing another hypothesis called thrifty phenotype hypothesis. This means that there may be genetic reasons why people are less efficient producers of health even with the same resources. The early depreciation, if any, even if we are quite rational in terms of our spending, economical spending, the because of early deprivation etc., this has thrifty genes activation, and because of the thrifty approach, what really happens, there will be negative adult health outcomes, and it has a long consequences with its early deprivation. But the emphasis here is through thriftiness, right. So, for people or sorry people with activated thrifty genes may not be acclimatized to abundant conditions, okay, condition, and may develop diabetes, obesity and other disorders. And this was in fact proposed by Hales and Barker in 2001 in their article with the same title, that is thrifty phenotype hypothesis. And this is also largely referred to as Barker hypothesis, okay. And randomized experiment like Rand's health insurance, which we have already cited in our another lecture, that this is not actually possible, okay, when we are referring to the thrifty phenotype context. It is not possible to check causality due to ethical reasons, and hence we need to go for neutral experiment, such as, so randomized experiment like Rand's health insurance experiment is not possible to check causality due to ethical reason. Use natural experiment such as other factors which are not through these thrifty approaches. Third one is called direct income hypothesis. As the word direct is written, that means it is related to your direct incomes. Health disparities arise because the rich people have more resources to invest in health. This is also referred to absolute income hypothesis, which states positive relations with income and health. In this figure, we can easily see that the rich as against the poor. Okay, the rich people has more money to spend on H. Okay, H here we have taken H, and other consumption goods we have taken as X. So, rich we have identified this, and utility out of the rich people and poor people, and they have different possibilities as well, and hence their choice for health as against other commodities are different, and it is clearly differentiating their status, socioeconomic status. Next one is called allostatic load hypothesis. This was attributed to, this is attributed to McQueen and Taylor in 1993. This emphasizes stress as the mechanism linking socioeconomic status and health, and an individual with prolonged or repeated stress faces a higher depreciation rate and chooses a lower optimal health level. So, Whitehall 2 study by Michael Marmot, stress and health study are actually emphasized. We will be discussing in a short while. As I already mentioned, this was by these two authors with the period 1993. So, we are now clarifying these with example. Whitehall 2 study by Michael Marmot, and emphasizing short versus long term stress and its implications on disparities. In 1985, Professor Sir Michael Marmot led the group of epidemiologists started stress and health study, also known as Whitehall 2, okay, which was established to investigate the causes of social inequalities in health among civil servants. The study is named after Whitehall area of London. That is due to an area is actually named with Whitehall 2. The Whitehall 2 study has shown the importance of psychosocial factors such as work stress, and we are actually emphasizing at this moment on psychosocial issues such as stress, and work family conflicts in heart disease and diabetes etc. are emphasized. This study is still in progress, and recently it completed its phase 13 in the latest year 2023. Hence, it is relevant for research. You can think of, as I already mentioned through their work, that stress has short term and long term consequences, especially it will be our choice function will be suboptimal in the long run. Short term stress, especially maybe like exam stress, that releases hormone to increase metabolism and efficiency, whereas in long term like stress in office etc. This has prolonged and consequences, and this long term stress is considered to be prolonged, and this is usually repetitive, okay, and hence unhealthy exposure leads to memory loss, strokes and neuron deaths etc. So, there are different interpretations for short term and for the long term. Yes, in the short term might be efficient to some extent, but in the long run might be creating problem. In their work they emphasize on long term issues largely. Now, another one is called access to care hypothesis. We have already mentioned that we are linking with SES to health in all these directions, isn't it? So, difference in health access to healthcare leads to health disparities. More income, more generous health insurance that lead to more lavish healthcare. Like we refer the work Widman et al. In 1995. People who self-reported low access to care have higher hospitalization rate for chronic conditions such as asthma, hypertension, congestive, heart failure, etc. These cases are preventable with increasing access to care. Oregon Medicaid study emphasizes on this aspect and discuss about access to care if it is increasing, early diagnosis of diabetes, etc. Medications also cases are expected to be higher and will actually deal with the issue. Okay. So, you can check with this example in a search and you will find that how care is emphasized. Next one is related to a productive time hypothesis, and where worsening health diminishes productive time and hence the ability to effective in your work, and that may reduce your income if your productive time is actually compromised. So, we start with like anemia if any is there due to iron deficiency that result in lethargy and inability to concentrate. Hence, it has consequences in terms of capacity to work. So, there will be low capacity to work, higher the health, better the productive hours we have. We already discussed earlier this kind of diagram. This is also called production function of the productive time. Okay. Then last one is Fuchs hypothesis. We discussed in our chapter, previous chapter as well, previous unit lecture as well. We mentioned about time discounting. Actually, individuals with a lower rate of time discounting who have more patience invest more in both health and education. An utility function we defined that over the time we are actually discounted. Later on our actually additions to our utility diminishes. Okay. And hence we also discussed this in Grossman's model, multi-period model, and this was actually discussed with the name called with the title as multi-period Grossman's model, and this was discussed in fourth lecture of this unit. This hypothesis was first discussed by Victor Fuchs in 1982. In his paper, Victor Fuchs observed correlations between socio-economic status and health, that is largely caused by patience. Patience is actually is responsible for discounting usually. Okay. So, what are the conclusion out of our discussion? Here each theory that we discuss in this lecture aligns with the principles of Grossman's model. Each theory is backed by evidence from various sources and adds in clarifying reasons behind the difference in health related outcomes and factored in through socio-economic issues or vice versa. Researchers striving to study health disparities ought to examine these hypotheses, as they may encounter unintended outcomes in their study of health disparities. Whiteman study is also relevant for research, and you can find out this is what I discuss. Whitehall study, Whitehall 2, as I already mentioned, phase 13, this is still continue till it is phase 13. You may please have a check if you read Whitehall's work in the context of allostatic load hypothesis, that might be relevant for your research as well. And now we need to also explain you what we have done it in the entire unit number 2. Before we finish unit number 2, let us have a complete discussion, complete summarization. Health as a we discuss about health as a stock variable in our chapter health and utility. Concept of health state dependency was emphasized, if you remember well, and a model of consumption and health was discussed. Lifestyle choices and health was also emphasized. Okay. Then we discuss about price responsiveness of demand for healthcare with the evidences through randomized experiments. We discuss about RAND, health insurance experiment and Oregon's Medicaid study, and we also compare these two in the context of demand for healthcare. So, Grossman's model of demand for health, we also emphasize on single period and multi period context, and time as a constant in your model we emphasize by taking 24 hours how it is allocated, and the production function with health as a product and other than health, that is X is a product. We discuss health as a consumption good and input in production function, and also and a form of capital. Wagstaff, especially in this lecture we discuss about Wagstaff idea of demand for health and its variations with price, income and technology. Socioeconomic disparities are largely emphasized. Okay. So, these are all for better reading, we will suggest this, and the original reading is here. Okay. And even we tried our best to refer to the latest books, and chapter number 4 is emphasized. Okay, so that's all. What is there in the next lecture? We will discuss in the unit number 3 on supply side of the health issues, especially healthcare, and the nuances of supply side will be emphasized largely. I think I hope you have understood entire demand modules on healthcare. If you have any queries, please don't hesitate. We will be happy to address your queries. Thank you.